Good evening, everyone. My name is Lanice Williams, and I am the Vice Chair of Women in Global Health's Washington, D.C. chapter. Thank you for joining us this evening for this virtual event on addressing the persistent disparities in the HIV/AIDS response. This event is brought to you by the Women in Global Health DC chapter. Women in Global Health DC is one of the 23 Women in Global Health chapters. Women in Global Health, which is a 501c3, was established in 2015 as a movement to elevate the leadership of women in global health institutions and to expand gender equity in the delivery of healthcare around the world. WGH has more than 26,000 supporters across 90 countries, and the DC chapter has a network of over 200 members. During this evening's event, we will be live tweeting, so please be sure to tweet and tag us at WGH in DC. I also want to thank HipPolitics for co-sponsoring tonight's event. And also thanks to Jen Cates, Senior Vice President and Director of Global Health and Health Policy at the Kaiser Family Foundation for moderating. Tonight, we'll be discussing how to continue addressing the ongoing disparities that exist within the HIV/AIDS response for Black and Latino women and the impacts of COVID-19. The HIV epidemic continues to have a devastating impact on the communities of colors and key population around the world. Although advances have been made in prevention, screening, and treatment, 1.7 million people were newly diagnosed in 2019, and 690 people died from AIDS-related illnesses. In the United States, particularly hard hit are the Black and Latino communities. While access to health services are challenging. In 2018, approximately 42% of those newly diagnosed with HIV are Black and 27% are Latino. Among those who were newly diagnosed, 58% are Black women. Indeed, women account for more than half of the 38 million people living with HIV worldwide. We hope tonight's discussion will assist the global and public health professionals with developing concrete actions to tackle complex issues that impact our community. Throughout the event, please be sure to enter your questions and comments in the Q&A box, and throughout our event, there will be time to ask Congresswoman Robin Kelly questions, as well as questions to our panelists. Now I'm pleased to introduce our keynote speaker, Congresswoman Robin Kelly. Congresswoman Kelly represents Illinois' 2nd Congressional District. She's an advocate for gun control, economic development, and reducing health disparities that affect her constituents and the African American community. She's the co-chair and co-founder of the Congressional Caucus on Black Women and Girls, and she also serves as the chair of the Congressional Black Caucus Health Brain Trust. Please welcome Congresswoman Kelly. You're muted at the moment, Congresswoman Kelly.
Oh, thank you. Thank you, Lanice, and good evening, everyone. As mentioned, I'm Congresswoman Robin Kelly, and I chair the Congressional Black Caucus Health Brain Trust and co-chair the Congressional Caucus of Black Women and Girls. Until this Congress, I also served on the House Foreign Affairs Committee and had an opportunity to work on global HIV/AIDS issues in that committee. I know that I don't have to tell you that we are on or could be on the cusp of seeing an AIDS-free generation. About 5 years ago, the UNAIDS Commission issued a now famous report detailing that if we could find the political will, an AIDS-free generation could be realized. However, the report also warned that if we failed to take aggressive and necessary steps, we could risk backsliding on our progress. I'm not interested in going backwards. We've worked too hard and come too far to allow politics to stop us from saving lives. One of the greatest challenges to this effort has been an unreasonable attempt to divide the HIV pandemic into a US epidemic and a global epidemic. The idea that our country is isolated from larger global public health is elitist and foolish. HIV should have taught us that, and COVID-19 certainly has. Public health officials across the globe warned us that the COVID-19 pandemic could derail the progress in the fight against HIV. First, by making antiretrovirals harder to find because global shipping had slowed. Second, because of a lack of access to healthcare or foregoing access because of COVID-19 infection fears. And third, people who are infected with HIV/AIDS have a higher rate of mortality from opportunistic infections like COVID, which means it is more important than ever that we all wear our masks to take care of others who might have weakened immune systems. No one wants to get someone else sick. Under President Obama's leadership, the wall between international and national started to come down under someone we've seen a lot recently, Debbie Birx, Dr. Debbie Birx, during her term as Global AIDS Ambassador. As you know, HIV/AIDS programs, domestic and international, took a hit during the early days of the Trump administration when the Republican-controlled Congress rolled back a number of programs, initiatives, and investments. But I'm so proud to say that when Democrats retook the House in 2018, we've been turning the tide and renewing our investments. At the end of July, we passed the FY21 funding bill and won an $11 billion increase over President Trump's budget request for HIV/AIDS programs. We also increased overall funding by $1.5 billion over last year's budget. The greatest increases went to NIH research funding to further our quest for a cure. We also secured an additional $430 million for housing opportunities for people living with HIV or HOPWA program. Beyond domestic funding, Congress also passed House Resolution 517 in December of 2019, which reaffirmed our commitment to the Global Fund to combat AIDS, TB, and malaria. We were also able to ensure that Ryan White, PEPFAR, and a number of other critical HIV/AIDS programs were funded because we continue to see too many new infections, especially in African American communities, as you just heard. The first and largest group is African American MSM men. While the rate of infection for this population was growing out of control for many years, it is now going down for all age groups except for 25 to 34-year-olds. Despite being a relatively small sliver of the overall population, Black MSM men make up more than a quarter of all new HIV infections in America and nearly 40% of all new infections among MSM men. However, the fact that we were able to reverse the trends in most age groups shows that our program works if we fund them. Moving on to Black women, we represent well over half of new HIV infections among American women. The infection sources for more than 90% of us is heterosexual sex. And we are seeing a remarkably shocking geographic disparity in the South. Black women represent one of the fastest growing populations for new HIV infection. So we really need to break down outdated ideas about HIV being a men's disease or a disease that doesn't impact women. One of the best ways to do this is getting tested and taking your friends, because tragically, there are many Black women living with HIV who don't know they even have the virus. I know it sounds a little scary and a little crazy, but let's face it, people look up to you. You can lead by your example. Each year, I join my colleagues in the bipartisan Congressional HIV Caucus, AIDS Caucus, and get tested on National Testing Day in June and on World AIDS Day in December. The CDC recommends getting tested every 6 months, so I make sure to remind my social media followers to get their test. When it comes to HIV and really so many health issues, we do have some control in our hands. First, we need to take ownership and ensure that we make good decisions and have a good primary care provider. Second, we know that not everyone is fortunate enough to have access to a doctor or health insurance. So we have to keep fighting and advocating for greater change and investment, because healthcare is a human right. I wasn't in Congress when the Affordable Care Act was passed in 2010, and everyone has their own opinion about the law, but there are a few facts that no one can refute. One, the ACA cut the excessive cancer death risk for Black men by more than half. Two, new HIV infections among Black women declined 21% from 2010 to 2016, which is a time period starting with the ACA enactment. Three, likewise, a decline in Black MSM HIV new infections for most age groups also corresponds with the ACA implementation. Four, the number of Black men without health insurance has been cut by more than half. So instead of working to tear down a system that's working, let's make it better. Let's make the safety net stronger and ensure everyone can live a long, healthy life. Now, I hope that gives you an overview of these issues and what my priorities are in Congress. Lanice, I think I'll stop there and take any questions.
Thank you, Congresswoman Kelly. If
You're
anyone
welcome.
does have questions for Congresswoman Kelly, please feel free to raise your hand and we can unmute your line and you can ask her those questions directly. Or if not, feel free to put them in the Q&A function as well or the chat box.
I think we have a question from Elizabeth O'Connell, and I've just unmuted her.
Hi, can you hear me?
Yes, hi, Elizabeth.
Hi, I'm Elizabeth O'Connell. I am a member of the Executive Committee of Women in Global Health, DC. And first of all, thank you all so much for participating in this discussion. And Congresswoman, thank you so much for your leadership on these issues. A question regarding PEPFAR. I was wondering about your thoughts on changing guidance or regulations so that PEPFAR can purchase and distribute contraceptives, particularly in areas and in countries where there is no USAID family planning program and where women's access to contraceptives is particularly challenging. Thank you.
I've never had that discussion with anyone, but I would not be opposed to that. I remember visiting a country in Africa and speaking with some of the leaders of a particular village, and they were just sharing, you know, how young girls were when they started having babies, and they would get married at very young ages, but also, but the men, even though they would marry, they had, you know, more than one female in their life. And I think that we need to do what we can to protect from diseases and also protect from having, you know, so many children at such a young age. And then also that will cause them not to finish, you know, their education and those kind of things. So I would not be opposed to that idea. I have not been a part of any conversation around that, though.
Thank you.
It looks like we have a question from Nyla. Liz, I'm not sure if you can unmute her. If not, there's a question from Nyla.
Hello.
There she goes.
Hi.
Hi, how you guys doing today? I had a question. You mentioned Obamacare helped with the decline of the rate of HIV. I was wondering how exactly did that happen?
How what?
How the Obamacare, you said the Healthcare Affordable Act, how did that help with the decline of HIV spread?
Well, because more people had insurance and more people were taking advantage and going to the doctor, I think, and more education around healthcare. I mean, one of the stats I talked about were Black men that weren't insured were insured now. And so then they could find out if they had HIV. That's one of the big problems, that people don't know, and then they spread it to other people.
Thank you for that question. And I know we have another question from Ella, and I'm not sure, Liz, if you can unmute her so she can ask the Congresswoman her question directly.
Hi, can you hear me?
Yes. How are you?
I'm great. Thank you for asking. How are you?
I'm good.
First of all, thank you so much for the opportunity to have this discussion, because I feel like women's health gets placed in a particularly interesting area where it just kind of goes unnoticed, especially when it comes to women of color. So I wanted to know the prevention programs that you mentioned, because we talked about the Affordable Care Act and Obamacare, and I wanted to know what are the existing programs that people can go to for testing, for just overall awareness about HIV and AIDS.
Well, I mean, there's so many, I don't know every program in across the country, but you can go to your even federally qualified healthcare center to get information, to get tested. There's different types of programs all over. It's just they may not be under the same heading.
Right. And sorry.
And I wanted to tell you that I appreciate your comment of what you said about women, because I do a lot of work around maternal mortality and morbidity. I do a lot of work around that, and especially for women of color, where it happens to everybody, but you're right that women of color have far greater effects, with that also, just like with HIV/AIDS.
Exactly. And I am worried that, the threats that are posed against the prevention programs that already are put in place. Do you know some of the threats that are
You said the threats?
Against? Right, because I feel like people place healthcare under political movements, even though that affects large communities, and it affects people who can't afford these healthcare services sometimes. And right now we're in a very interesting time where it's like we're starting to even see the decline for services for COVID, like you were mentioning. So I kind of really want to know, what are the obstacles that we're facing, that you see as a congresswoman, that maybe we can try to fight against more directly?
Well, unfortunately, this disease has become political. Like, it should be political to wear a mask or to socially distance. And, I try to work in a very bipartisan way, but ever since, President Trump has been in, he's tried to take apart the Affordable Care Act, however people, feel about it. More people did get insurance, but in my time there, we were never given the opportunity to improve it because we just didn't have, we were in the minority, but now that at least we're in the majority in the House, that's why we're trying, and the budget starts in the House. So as I was sharing about, we tried to improve the budget, but the honest to God truth is voting has consequences. And also I will say to everyone, because it's, not September 30th yet, that you have to fill out the census, because that dictates where a lot of money goes to programs. And if they don't know you people exist, then you will get less money. So, and healthcare is a big part of it. So people have to make sure that their voices are heard through the census and also through voting.
Okay, thank you.
Thank you so much. I'm not sure if anyone else has any other questions for Congresswoman Kelly. If you do, please raise your hand. If not, thank you for those that did ask questions. Again, we do have one that just came in from Shirley. I'm not sure if you can unmute her, Liz.
Hello, can you hear me?
Hi, Shirley. Yes, we can hear you.
Hello, Congresswoman.
Hey.
Sure. Your presentation. Yes, my question is related to the to prisons and more access to education and prevention methods. Are there any discussions regarding things like condom use, more education in prisons?
Yes, we've had, I'm not on those committees, but there has been discussion period about especially women getting treated better in prison period, like, shackles, when they're pregnant and different things like that. So we are having conversation around a more respectful environment for particularly women that are in prison. And I think that really it depends on, I've been in different prisons and you just see different levels of care and education and professionalism. And, hopefully we can get, all prisons up to the same standard.
Thank you. And among men in the men's prisons, and I say this because we've had recently a client that was a young was in a relationship with a man who just came out of prison, and so it seems like they weren't enough education, enough prevention for that to happen, and unfortunately she got infected with an STD.
Wow. Yeah, there needs to be more education, period, even, whether it's prison, whether, I know some people don't like to hear this, whether it's in schools, I know people don't want that kind of conversation, but it's necessary.
Thank you very much, Congresswoman.
You're welcome.
Thank you for your question, Shirley. I was just wondering, Jen, Regan, or Monique, if you had any questions that you might want to ask the Congresswoman while we still have her. I would just say, if you have something you want me to know or want me to take back, tell me that also.
I'll jump in. I just wanted to say thank you, Congresswoman, so much for your leadership on this, but also your point about the domestic and the international intersection, because, COVID is calling into, stark relief that obviously we have to end it everywhere. And certainly the U.S. has an unmitigated response to COVID, and we also have an unmitigated response to HIV. And I'm an American living with HIV, working for a global organization. And I think it's really important for the world to see a developed nation struggling with these issues, and also to see our leadership, to see our ability to solve healthcare in our country and to address these issues for women, in particular women of color. So I just wanted to say thank you for your leadership. It's really, really important in this moment, and we stand behind you in our desire to make people realize that we will never end any pandemic unless we end it everywhere, and of course for all.
That's right. Yeah. I just had that conversation with, I can't remember who, but with someone today that, we're really not an island. And we have people coming in and out of this country, and we go in and out of, other countries, at least the ones that accept us now, but that we have to be team players and leaders also.
Yes.
Yes. Thank you again, Congresswoman Kelly.
You're welcome.
For your schedule to join us this evening. We really
welcome. Take care.
You too.
Okay. I'm just a phone call away.
All righty. Thank you so much.
Thank you. Thank you.
You're welcome. And now, before I turn the event over to our moderator for the evening, I just wanted to give you guys a little bit more about Jen Cates. Again, Jen Cates served as the Senior Vice President and Director of Global Health and Health Policy at the Kaiser Family Foundation, where she oversees KFF's policy analysis and research focused on the U.S. government's role in global health and on the global and domestic HIV epidemic. Jen, it's over to you now.
Great, thank you, Lenise, and hi everybody. It's great to be here. Thank you so much for joining us, and thanks so much to Women in Global Health DC at HipPolitics for hosting this and asking me to be part of it. I'm really excited to be able to be here and to talk about this important topic. I was thinking about what to say to frame our discussion, and I feel like we're in such trying times. It was really hard to come up with the right words to express, where we are, but also to try to convey some hope. And I hope that we can, tonight have the real conversation about what needs to happen to address disparities that are affecting communities of color and women, particularly women of color, with HIV, but also COVID. There's really no easy answers, but I think we have two great speakers who can help us. So two things I wanted to say before I just briefly introduce them that I think are important points to keep in mind that I always think about in the context of HIV, but they're both the same kind of phenomenon happening now in COVID. The first is the disparate impact of HIV, particularly in communities of color, started from day one of this epidemic. From the very first cases that were later realized to be AIDS, there was a disparate impact on people of color, particularly Blacks, in the United States relative to their population, but nobody noticed. I'm not saying the community didn't notice, but official government, official organizations, this disparity was not noticed until it was too late. And in the intervening period, HIV spread and the disparity got worse. This is exactly what's happening with COVID. The disparity has been from day one, and it's increasing over time. Second, another important point that I think we should just keep in mind is that the disparity is not due to anything inherently different about the individuals who are infected. It's almost completely a function of the systemic and structural barriers in which they live their lives. That is putting them at increased risk of becoming infected with HIV, of becoming infected with coronavirus. And then once they are, making their ability to seek the services they need because of access issues, because of discrimination, because of a whole range of factors, harder. So I just want to, as we go into this conversation, I just want us to remember that those two things are really important. The disparity has been there from the beginning, and the disparity is the result of structural societal factors that exacerbate over time. So with that, I'm going to briefly introduce our two panelists, let them say a little bit about their perspectives, and then we'll have a dialogue with them and go to your questions. So first is Regan Hofmann, who already you heard a little bit from, who's the director of the U.S. Liaison Office of UNAIDS. Regan, who, as she mentioned, she's HIV positive. She's been living with HIV since 1996, is an activist, a global health consultant, an award-winning journalist, and a published author. And I would just add an amazing speaker, amazing advocate, an amazing coalition builder, and someone I call my friend. So it's great to see you tonight. And also Monique Campbell, who is the Peer Education Center and Youth Testing Coordinator at Whitman-Walker. She's been working in public health since 2012 and has been part of Whitman-Walker Health since 2015. She graduated from Howard University, just down the block from me, yay, and is a certified clinical medical assistant. And she was an HIV tester at Metro Team AIDS in Washington, D.C. And I'm excited to say I am on the board of Whitman-Walker Health Policy Institute. So I'm a big fan of Whitman-Walker. Yay. So Regan, I'll start with you to let you, tell us how you want to think about this tough topic. And also, I know UNAIDS just came out with a really important new report. So over to you.
Jen, and thank you for your kind comments. And this woman is one of the great leading voices on HIV in the world. So we're lucky to have you with us tonight. And thanks to Women in Global Health for hosting this, and HipPolitics and Monique. I have actually been a client at Whitman-Walker myself when I lived in Washington, so a lot of connections tonight. But I just, Jen, your points are really important. I think this is not news. We've had disparities in health and infectious diseases since the beginnings of any of them, be they HIV, COVID, or others. As you mentioned, I was diagnosed with HIV in 1996. There were very few groups for women. When I finally found them, they were full of African-American women. I got HIV because I did not think it was going to happen to me. I was just unaware, really, that this was something that really was a high risk for women, and I let down my guard after I was divorced and got it through heterosexual sex. One time, one person. So it's really, it was a shock, and the system wasn't there to really help me and address me or address my needs at the time. And it's gotten better over the years. But as you point out, Jen, I think that where we are in the HIV response and where we need to be in the COVID response is understanding these structural and societal drivers that both put people at higher risk and then make it more difficult to access care. So you're right, UNAIDS just released a new report that examines the intersections between HIV and COVID, and it's called COVID-19 and HIV, One Moment, Two Epidemics, Three Opportunities. And because there are so many similarities between the epidemics, we look at taking the learning from HIV to apply to COVID, leveraging the infrastructure, the knowledge, the labs, the people, the community-based leadership that we have for HIV, applying that to COVID, and also looking at this moment. I think, to your point, Jen, as a point of hope, this is a pivotal moment in which the world is awake to the fact that we need to end infectious pandemics for everyone, and that it doesn't work if we only end it for some people. And so with this heightened awareness and the colliding epidemics, it poses the question, how do we accelerate progress on multiple epidemics at once? And that causes us to reevaluate how we address healthcare for people. And that's, that takes us right into the conversation about equity in healthcare, access, in healthcare. And we also released another report recently called Rights in a Pandemic, which examines some of the human rights issues that we're seeing in COVID. Because as we've seen in HIV, if we don't protect people's human rights, it's very difficult to deliver care and services to them and help people get tested. And just one more point here, I'll just say to the Congressman's point about testing, knowledge is power in health. But of course, with the stigma that comes with disease and with the challenges that people know are surrounding accessing care, it's really important that we think about how to protect people's human rights and encourage people to get tested and to connect to care. But we'll come back to some details. But just, thank you for having me here, and I'll pause there over to you.
Great, thank you. More on all of that. Monique, I was thinking, I work on policy, so I'm looking at legislation and policy issues and analyzing them. You're on a daily basis dealing with people's real lives in your work, and I assume, seeing these issues on a daily, hourly basis. So I'd love to hear from you about, your perspectives coming into this conversation. Thanks.
Yeah, thank you. Regan actually hit the nail on the head. She basically said everything that I was going to, but I also have a different perspective because I work for Whitman-Walker Health, but I also work with the younger population. I work at our youth services site. So we service a population from 13 to 24 years old. And it's really hard because my location is located in Eastern Market, which is in Ward 6. And, Ward 6, 7, and 8, specifically Ward 7 and 8, are the poorest wards in DC. So those are the people that we serve, and they are the ones who have the hardest time, just from my work seeing day to day, have the hardest time, even receiving our services, even having bus fare or smart trip fare to even get to our offices to even receive our services or receive referrals or whatever the case may be. So I'm very, very grateful to Women in Global Health DC chapter for even shining a light on this topic, because it's a very serious thing.
Thanks. Actually, I'm going to stay with you, Monique, for a minute and ask. So I'm, now I imagine that you're having to deliver services in a different way because of COVID, and how is that, which is affecting everybody. But how do you see that playing out, particularly for communities of color who might be, and young people who already face barriers? Or is it creating new barriers? Are you able to reach people that you might not have been able to because the bus fare issue maybe isn't a problem? I mean, how is it, what's going on?
So it definitely is creating new barriers. I am actually on maternity leave still. However, I was still at work when in March and a little bit beginning of April, when it was like, I mean, it's still a pandemic, so it's still very serious, but when everything like first hit us, and it was very, very difficult. We closed down our Eastern Market location, which is the site that sees all the young people. And we've been at our main clinic, which is on 14th Street Northwest. So it's been very difficult, you know, like I already said that, you know, having transportation has already been an issue. So of course, that's been a barrier that's been increased. We have taken to social media, you know, young people they have TikTok, they have Instagram, they're on Twitter. So we've taken to social media to reach them in those ways. They, you know, hit us in the private messages to let us know if they're having any issues, if they have any questions. Even though most of us are working from home, we still have our office line that rings to us, so they can still reach us. We have, of course, different hours for testing, different protocols. We actually just opened up testing at our Max Robinson site on MLK, and that happens on Mondays and Wednesdays between 12 and 4:30 p.m. So we're now trying to see how we can reconvene our programming that we had. We had daily programming for the young people. We've also taken to social media platforms to post those things as well.
Great, thanks. Regan, can you talk more about the report, the COVID HIV report, but also just generally, like, what do we know so far about the impact of COVID on HIV services, and how might that be particularly an issue for women and young women? And what are some lessons that we can take from HIV to help the global response on COVID?
Great, thank you. Well, we did a modeling exercise with the WHO that showed that the interruptions in treatment could lead to an additional 500,000 deaths among people living with HIV if we didn't mitigate them. So we've been moving quickly with countries, and you know, obviously our PEPFAR partners and Global Fund partners in the field and the countries themselves to try to remedy everything from stockouts to people's inability to get to clinics. And one of the things that we're doing actually is looking at new ways to dispense treatment. So multi-month dispensing, giving patients 3 to 6 months of treatment at a time, so they don't have to keep coming back to the clinic, is one way that, you know, we've been talking about that for a long time. And actually COVID has accelerated the policies around that, making that possible. It's even happened in the United States. I mean, with insurance coverage here, you can only get your medicines every 30 days, but during COVID that changed. And I also can get them sent just to my home, which made my life enormously easier, because every 3 weeks I panic about being able to access my medicine, and now it just comes to my house. I don't know why it didn't for years, but it's wonderful. So there's some upsides to that. We also, you know, have seen the power of community leadership. It's really, really important. You know, we learned this in HIV, that when the community leadership understands what needs to happen, they're the trusted voice with people at risk for or living with a disease. And so very important to empower them and to work with the people on the ground when people are not certain about the government messages or the government response. So community-led, people at the center responses is really critical. And there have been some other, you know, better evolutions that have happened because of COVID. People who were incarcerated for sort of minor infractions in some countries have been allowed out of prison to get health care. We've seen some shifting in that. But on the other hand, we've seen some real problems, as documented in the Human Rights Report. For example, during the lockdowns, they were used to go after people for other reasons. In other words, a transgender person might be arrested for being out during the wrong hours, you know, allegedly for just being out at the wrong hours, but maybe because they were transgender. We've seen taxi drivers, you know, under arrest for taking women who were pregnant to hospitals to deliver babies when they weren't allowed out. So it's been a complicated matrix of good and bad things. And just, I'll put it in the chat box, but both of the reports can be found on UNAIDS.org, but they're full of details and also recommendations for what countries can do and what individual communities can do. But I think the main thing, you know, that we're seeing is this is really opening up dialogues with countries, some of whom are actually have perhaps not the best track records on some of these issues. And so it is recreating that space to talk about this and helping people understand that it is not, there's not a dichotomy between human rights and public health. You don't achieve public health unless you give people their human rights. And, you know, as my boss has been saying lately, it's a myth that those things are separate. They are intricately, you know, connected, and we can't ever achieve the end of a disease or public health without making sure that everybody has access, especially those who are most vulnerable.
Thank you. Actually, one thing you said I wanted to pick up on, you know, one of the issues in HIV that I think we've struggled with is not meeting people where they are because the way services are provided is not integrated. And so, and it got mentioned with the Congresswoman about the question around PEPFAR. Can PEPFAR pay for contraceptives? And if it can't, is it? So how do we integrate reproductive health and transgender care and LGBTQ competent services and the whole panoply of things that somebody at risk for HIV or living with HIV might need access to? What are, you know, is that happening? And I'll ask it to both of you first, Regan, is that happening? Or what are the barriers to making that happen? Would love your thoughts on that.
Yeah, you know, it's a challenge. As you know, we have some restrictive policies in some of the global health programs. Certainly the need is there, and we have seen progress on addressing multiple conditions and multiple needs in a single setting. And that's certainly true with HIV, tuberculosis, and malaria. We're looking at multiple disease responses when a client comes in. We're looking at, you know, pregnant women and talking to them about family planning and contraceptive for going forward, because we're also seeing women who are pregnant, for example, contracting HIV while they're pregnant or while they're breastfeeding. So, you know, there's a continuum of care that's needed throughout a person's life and different stages of life to continue to talk to them about these other issues. You know, as the world has gotten conservative in some ways, we are always challenged with giving people services that they need and giving people education that they need. But it is very, very important to continue to do that. I'll just mention one thing that we are also looking at, which the Congresswoman touched on, the ability to keep women and girls, in particular in secondary school, to keep adolescent girls learning and to give them the life skills they need and the education they need to both be aware of various aspects of life that they need to be aware of, but also to be able to, you know, earn a living and have financial autonomy, which definitely changes their health opportunities down the line. So we have a new initiative called the Education Plus Initiative, which we're going to release more information about soon, but it is focused on encouraging African nations in particular to keep young girls in secondary school, because there's a huge correlation between higher education and better health outcomes for young women. So, and we see that in this country too.
Right, and that's one of the unfortunate things with COVID, of so many young people being out of school.
Yes.
Yeah, that's going to be something we've seen the consequences of that for a long time.
Unfortunately, yes.
Monique, what about, you know, the young people that you help? I imagine that they're facing a whole range of issues, and narrowly helping them with one thing around HIV testing may not cut it, right? So what are some of the issues that you see coming up with them?
So outside of like not being able to help them with testing, Regan also touched on it about and you also did, about not being able to reach them where they're at, excuse me, because of COVID. Whitman-Walker Health, especially youth services, we are really, really big on outreach, educational outreach. Like, we're in the communities, and we're there where they can find us. If they cannot come to our physical location, that will be in their neighborhood, whatever time, place, date. So it's been people also rely on us outside of testing. They rely on us for food. Some of them, when they get to our center, like, we're their meal because when they get home, they don't have that meal. So that has also been difficult, trying to figure out like what resources we can give them to even like be able to say, hey, you can go to this place to get food on this days, or these schools are open and providing breakfast and lunch for you between these hours. So it's like basically trying to like get over all of the hurdles, you know, that they face.
Yeah, I think it's hard because so many of the programs, whether they're, you know, programs within the US or programs globally, are not always because of politics, but just because the way programs are structured, financed and funded, they're so limited in what they're able to do. So to be able to provide that full range of things is often just really hard for organizations. Another question I have, and this also ties, I think, the global and the domestic together a little bit. And Congresswoman was talking about the ACA and what difference the ACA made for people with HIV, and talked about the impacts there. And I know from research we've done, the ACA has actually led to increased coverage, insurance coverage for people with HIV in the US. And that in turn means more people can get onto antiretroviral therapy, become virally suppressed, reduce transmission, and also live longer. Globally, the big conversation going on is around universal health care. And I know UNAIDS is leading on that in terms of what it might mean for HIV and what we can learn from HIV for that, and also some of the challenges with trying to make sure that as the world moves that way, that the concerns of the most marginalized people with HIV and among people with HIV and those at risk who are very, you know, already are isolated, that they're not left behind. Regan, do you want to talk a little bit about what UNAIDS is doing there?
Sure. Yeah. No, our executive director, Winnie Nyima, is very supportive of the idea of universal health coverage, and it's something that obviously sits at the center of our DNA. You know, we believe in human rights and the right to health as a human right. So everybody should be able to access life-saving care and treatment and prevention. You know, we're not there yet, obviously, in many countries. But I think as countries move in that direction, and we have seen with HIV, we've seen transformations in countries because of the HIV response, building a platform for which, you know, through which we can deliver other types of healthcare. For example, cervical cancer. You know, UNAIDS is involved in the Go Further partnership, which is aimed at ending cervical cancer among women with HIV in sub-Saharan Africa. And we've used the infrastructure, the train tracks that we've built, you know, for PEPFAR to deliver other kinds of healthcare. So once you're there and you're talking to people and they're comfortable in the you know, clinics and with the healthcare workers and the community healthcare workers who go out to reach people, as Monique was saying, where they are, you know, there's no reason we can't deliver other kinds of health in that way. You know, I think there is a bias towards, you know, Jen, you mentioned politics and funding. You know, people obviously want to pay for specific things and get specific returns on investment. And I get that. That's, you know, that's the basis of where we've been with PEPFAR. It was set up to end AIDS, and the money needs to be sure to be applied to that. But I think we can do both. I think we can continue to make progress on disease-specific efforts and, you know, track that progress specifically against targets, but also use that as proof of concept for the value of universal health coverage. Personally, I also think that, you know, when you're first diagnosed with the disease and grappling with it, especially a very highly stigmatized disease like HIV, you might need very specialized care. You might need more time with people who really know a lot about that disease. And as someone who's navigated both HIV-specific healthcare settings and general healthcare settings, I can tell you, even in America, it's hard to go into a normal healthcare setting and feel comfortable with HIV. I was in a car crash a couple of years ago out in rural Virginia, and they had no idea what to do with me because they found out that I was HIV positive. And actually, I was waiting for a long time for someone to come in and help me in my room in the hospital. And a police officer came in and he said to me, "How did it happen?" And I thought he meant the accident. I thought he was going to take a police report. And he said, "No, how did the AIDS happen?" I said, "First of all, you're not a medical professional," but I talked to him a little bit about it. But I think we have a long way to go to educate healthcare providers in the general health systems so that they can feel comfortable themselves interacting with people with HIV or specialized concerns like COVID. But we're seeing, general healthcare systems take on a new disease like COVID and handle it well. I was actually, this is perhaps too much information, but it's maybe relevant. I had breast cancer in the middle of COVID. So there I was in an American hospital with HIV, breast cancer, as COVID struck, and how do you navigate all these things together, and watching the health systems deal with these. It's possible to do it, and it was done well in the hospital I was in Washington, thank goodness. But this is the moment to reconsider how we deliver health to the world, and we have to be bold and audacious and think about it differently. Sometimes I think we just need to refresh the language. I think there's a bias against the idea of universal health coverage. It may sound to some people like this is too big a goal or too expensive, but in the end, it pays for itself. We know that delivering prevention and health to people early on costs less than letting these things rage on forever and get to scales that are fairly manageable.
Great. I'm actually seeing that we're starting to get questions, and I'm going to encourage people to send them in. I think we should just start moving to the questions, because that we could. There's some great ones. I see from three different people, and I don't know if our host wants to ask them to speak their question, or you want me to read them. But we have one from Elizabeth O'Connell, and then Nyla McGee, and Shirley Rano. So I don't know if I don't think I can unmute people, but.
Yeah, I can go ahead and unmute people. I think Elizabeth, you're unmuted.
Yes.
Hi, it's Elizabeth again. I have a lot of questions. Very intelligent and inspiring women, so thank you very much. My first question is, as we are to a large extent an advocacy group and a group made up of advocates, what can we be doing better? Particularly from your point of view, we as a global community have been living with HIV, this HIV pandemic for a great many years, for decades. What are we doing wrong, and what can we be doing better?
I'd like to start. I don't necessarily think that we're doing anything wrong, but we need to continue to talk to our lawmakers, our council members, our ANC. I'm talking more from the community level because I work for a community organization. But tell them how hard it is to see, like, specifically in DC, like there are hospitals that were in Ward 7 and 8 that are now closed. UMC is closed, Providence is closed. Like anybody in Southeast that has a medical emergency has to be rushed through traffic all the way to a hospital in Northwest. Some, unfortunately, don't even make it because the ambulance is in traffic. Like, talk to anyone at the local level, at the political level, whomever will hear you, go to hearings, talk to anyone, just continue to do that work.
And I would just add that, UNAIDS would love to partner with you as an organization on some advocacy on the Hill. I think there's I think we can reignite the conversation, in particular on women and girls and HIV. We focused a lot on key populations, and that's so critical. We have a lot of different groups of people who are being left behind. It depends, interestingly, how we frame the groups, and I think the gender lens has been a bit lost, so to bring that back into the center of the discussion, but really to raise the urgency around HIV. It's a very difficult disease to message. Even when I talk to people, particularly at schools and younger people, I want to say, look, it's a disease that you can survive. The treatment is manageable. You can live with the stigma. You can overcome that. So please don't be afraid to get tested and access care. It'll save your life, and your life will go on, and you'll be okay. You'll be happy. And then on the other hand, I want to say, don't get this disease. It's incredibly, difficult and challenging, and it's not something that you want to face. So I think we've also had a dichotomy in discussing the progress we've made against HIV. We've made incredible progress, unprecedented progress. When UNAIDS set the 2015 targets for in 2015, we set targets for 2020. We're not going to quite reach them, but we've come pretty close to some of them, and in some countries we've even surpassed them. So we have proof of concept that we can do this. We just aren't doing it everywhere yet. And I think that's another difficult thing to message. It is possible. We have the medicine to prevent people. I see a question about PrEP. We can prevent HIV entirely. we can make sure that no woman has a child who's born with HIV. We can stop the disease and we can keep everybody with it alive. But we really do have to make it a priority. And I think COVID gives us an opportunity to do that. I think because the world is awakened newly to this importance of responding to pandemics adequately and quickly with adequate resources, now is the moment. The next 6 months, really, we could do some powerful advocacy on the Hill. It's interesting to watch the debates around the funding behind COVID globally. It's a really important moment, but it's stalled out. And what does this say? The world is facing one of the worst diseases, new diseases it's seen in many decades, and yet we're frozen politically on it. So we need to change that.
Thank you. Why don't we go right to the PrEP question and come back to Nyla's question about stigma. So I think, Shirley, you are unmuted.
Yes, thank you. This is Shirley again. Thank you both for your comments, your presentation. And so yes, my question is focused on PrEP. I wanted to know what both of your organizations are doing locally with like Monique and also Regan globally. I know those can be two different scenarios due to the procurement of the medication. So it'd be great to hear what your organizations are doing about PrEP specifically on women, or for women, the education and the uptake.
Do you want to start?
Yeah, sure. So for Whitman-Walker Health, we host on, again, we've went to social media because everyone has Instagram. We host every week. We have PrEP talks with we have dedicated PrEP specialists. So they're online talking with anyone who just wants to know more information about it. In-house, we have testers who do our HIV testing. They will speak to every client about PrEP, give a little bit more information, and then hand over any client or patient who would like more information or would like to schedule an appointment. They hand them over to the PrEP navigator, and the PrEP navigator handles all of that information. I don't know if you are in the DC area or have been around. There are billboards everywhere, especially at DC Health. Actually, they usually have trainings, and there was one last year, I believe, that was about PrEP specifically for women and women of color. So just we just put out the word and use give our resources on anyone who wants to have that information.
And then I think from our end, we're embarking on the creation of our next 5-year strategy. And one of the major points that we've been discussing is the need to redouble our efforts on prevention. I think we've made a bit more headway on accessing treatment for people than we have on prevention. So PrEP will be an important part of that, especially for women and girls. It's a very empowering tool because obviously it puts the control in the hands of women. And we know that that's often easier than asking partners to navigate condom use or other things. And just in the context too of giving women tools, one of the things we've seen in COVID is actually a rise in gender-based violence, both in marital settings and in extramarital settings. So, we do need to give women and girls all the tools they need to protect themselves. And I think maybe come at this from an advocacy perspective in a slightly fresh way. PrEP is a very powerful tool for all genders, and it can be a very powerful form of prevention. We are far off the global goals of uptake for PrEP, and I think it's just a function of, again, redoubling the efforts on education and awareness and making sure that we're getting the treatment to people. But it's certainly very powerful. And I think it also, someone asked a question about how do we reduce stigma. Stigma around HIV is so difficult in some ways, but I think it can be reduced by people with HIV talking about HIV and helping people understand it. In my own arc of a life of 24 years with this disease, I've talked to a lot of people about it. Some people have been okay with it. most people have, some people are not. But I think when people realize that you're not infectious, that you're on medication that makes it impossible or virtually impossible for you to transmit the disease, and when they realize that there's a medication that they can take to protect themselves, it definitely changes the dialogue. So I think in addition to making sure we deliver PrEP to those who need it, using it in the conversations around reduction of stigma is a helpful thing as well.
Great, you actually answered one of the questions that someone was trying to ask and we couldn't get them on video. So please keep asking questions. I wanted to say one thing about PrEP and then also something, I hadn't thought about it till I heard this, you guys speaking about stigma, but on the PrEP side, just so everybody knows who's listening, in the US now, you should be able to get PrEP for free if you have insurance. And then if you don't have insurance, there's a program that would provide you with PrEP. So one of the reasons that some people and women are not accessing PrEP is they might not know about it, they might not understand what it does. So if anyone has that question, we can explain it. But the other issue is people are afraid that it's going to cost too much. And actually that, as of relatively recently, is not a barrier in the US for the most part. So that's a good thing. The other thing I was thinking about around stigma is a lot of the activists in the HIV community, just by nature of trying to, having to confront a new epidemic when it first emerged, have been on the front lines of trying to raise awareness about COVID. And I think that's a really important thing, and I've already made a lot of contributions, whether you're talking about Tony Fauci or a lot of just advocates, working to try to get their local government and federal government to do more. So I don't know if that will reduce stigma, but it does show how I think one community is able to bring those lessons to the current crisis that we're facing. I'm not seeing another question yet, but I had another question, which is, one of the topics that we were sort of undergirding all this conversation is structural racism and how to address it in healthcare and racial disparities. And we get asked this a lot too. What can organizations do to take this on, which is just such a huge, pervasive challenge that really cuts through everything? And what are steps that we can take, that you take in your work or that your organizations are taking to try to even just chip away, if possible, at these barriers? I know that's a really hard question, but if anyone, either Monique or Regan, wants to jump in on it.
Yeah, it's a really difficult question, and I think it reminds me a little bit of sort of the messaging and discussions around gay marriage. When we went through that and pushing for gay marriage, what really seemed to work was focusing on equality of all people. Are all people equal? Then if all people are equal, they should have equal access to all things, right? So the end. And for me, obviously racism is driving disproportional disease burden among certain parts of the population. I don't have the answer, obviously, myself, but I think perhaps it lies somewhere in bringing people's minds back to the fact that we need to end human suffering. There are lots of people who are suffering, and it doesn't matter where they live or what they do or who they love or whatever. Can we start with a common humanity here, where we have, again, a disease that doesn't need to affect people or kill people, and how do we approach all people with that? And Jen, you made the point, that I think just acknowledging that we have a disproportionate percentage of people of color who are doing frontline work, whether that's, in transportation or providing food or healthcare services. When I was in the hospital, many of the nurses, male and female, that saved my life were people of color, and actually people of color from other countries, because it was a teaching hospital. So I think we need to recognize the higher risk for certain populations and make people understand also that they are the frontline heroes. They are the people who are actually keeping the rest of us alive, and they deserve to be treated better and protected better.
Thank you. Please, I'm not seeing any other questions come in, so unless I'm missing them, I hope others are thinking of their questions and bringing them in. I realized one of the things that we didn't talk about from the outset or just lay out for people is what some of the, and it's come up a little bit in conversations, but what are some of the risk factors that women face, particularly young women, in terms of putting them at risk for HIV, whether it's in DC or it's in another part of the world, just so people understand what the multiple risk factors or challenges that women might face that put them at risk. Does either of you want to start on that one, or?
I mean, we know in South Africa or Sub-Saharan Africa, for example, young women are disproportionately at higher risk for HIV. Part of it's biological. Part of it's the way that the virus enters the body, and women's bodies are just more receptive partners. Bodies are just more susceptible to the virus. It's why even when we circumcise men, it lowers their risk. It's just the mechanics and the biological reality of the disease transmission. But it's also structural and societal, as you said, Jen. It's whether women and girls have access to prevention that they need, whether they're safe from gender-based violence, which certainly can spread HIV, whether they are having survival sex or needing to engage in sex work without protection because of financial reasons or just the environments. So I think it's about looking at those structural and societal drivers that make women more vulnerable and address them. And then I think some of the things that Monique was saying just about, being able to physically access the healthcare services and what you do with children. If women have the burden of caring for children or educating them at home, and women in COVID are under a lot more pressure in some ways. So how do we help them with the multiple things that they're facing? So I don't have quite good answers, but we're aware of the needs. So maybe Monique has some solutions.
I don't. I'm just sitting here agreeing with everything you're saying. I'm like, yeah, Regan has it all.
I mean, and
So,
really,
I don't. Yeah.
Sorry, go ahead.
No.
I just was remembering when we were talking about getting more women into clinical trials and what were the things that were going to enable that to be the case. And one of the issues was transportation. One of the issues was childcare. How do we get women connected? And so, and I'm always struck by that, the issues of childcare. When I am in the field in Africa in particular, you see clinics with everyone has their kids with them, and they're there for hours and hours and hours, and it's like 1,000 degrees, and there's no food or water. So, how do we address that better? When we think about this.
Yeah, I have a question that Monique, you may have thoughts on this, and Regan, you may have thoughts on this. If not, I'm happy to share. So in the US right now, we have a national initiative, the Ending HIV Epidemic Initiative, that was announced by the current administration to address the domestic HIV epidemic, to drive down new infections. Do either of you want to give like a brief overview of what it is from what you know? And then do you think that the initiative is addressing the needs of women and the needs of communities of color from what you could tell? Has it taken that on? Is there more that it could do? I just don't know if our audiences are aware that this is actually a current initiative, which is an important one.
I'm happy to offer a few thoughts. I mean, I think my main understanding is that the money had been flowing to epicenters basically on the coast and sort of in the north. And we looked at the CDC data over time and realized that we could pinpoint exactly where the sort of hotspots were. And this new approach, which actually mirrors what we did with PEPFAR, the UNAIDS provides the strategic information for the global AIDS response. And when we look at that better and more real-time data, disaggregated data, it gives us a really good steer towards where we can have the highest return on investment in terms of saving lives and also just reaching people. So I think we've done a similar thing with the Ending the Epidemic plan in America, where we know where people are, we know where we need to reach them. It seems like the numbers have gotten a little bit better, both for African American men and gay men, with the exception of the very young population in that subset of people. And women seem to be getting a little bit better, but flatline's not okay. We really should be seeing these curves go steeply down. And I this is my own guess and estimation, but I really do think that it's true in the global and it's true in the United States. We've reached the people that we were going to easily reach. And now we're faced with reaching people that are harder to face, either because they don't have health insurance, or they're, unemployed, or they're, more afraid of stigma or criminalization, or a variety of things. So we need to really get into the communities and let the communities tell us what they need, and talk to the people who we have yet to reach and understand what they need, because that's what works. Getting down on the ground and hearing people on the front lines, like people like Monique and people in clinics who are working every day with clients. Retention and care is a big issue. And that's another question. We see a lot of people coming on to treatment, but not necessarily staying on treatment. And of course, someone has to stay on treatment to be virally suppressed over time. And so what do we need to do to keep people in care? And all that intel comes, it's more, qualitative, and comes out of the discussions with the clients in the clinics, and also out in the communities when they haven't come into the clinics yet.
Exactly, Reagan. That's exactly what we do at Whitman-Walker Health. We assess what the client needs. We always go into the community, ask, what is it that you need? How can we assist you? How can we help you? Just like, so you mentioned, a client not being able to, make their appointments or whatever to, maintain adherence. We have a whole team that will go out and pick up a client and bring them to the clinic and for their appointment, and then take them back. Or we've also been utilizing Uber. I myself have went and picked up a client for an appointment and waited for them at their appointment and taken them back home. We just try to do all that we can to minimize any barrier that may be there for the client.
And I think that taking the healthcare to them is such a great idea too, bringing them and helping them get to the clinics if we can, and then also making sure we take the healthcare out to the communities, which can sometimes be more time consuming or more expensive, but it's very effective. And then telemedicine. I mean, you've talked a lot, Monique, about how you can use social media and technology differently. That's something I think that we're also seeing with COVID, a lot of telemedicine, a lot of, it's a great way to accelerate care and treatment. And actually in some parts of Africa, we have better cell phone service than some parts of Virginia. So, I think if we can, leapfrog to using the technology that exists and innovate quickly, because of COVID, I think we can help accelerate further progress on HIV.
Great. We actually do have a really important question that someone just put in the chat box that I'll put up there. Could you both speak about U equals U, efforts to promote U equals U, what that means for those who don't know, and then also how it can help empower women with HIV? So either of you, Regan, maybe you want to, I know you and I have talked about this, so I know that you can talk about it for a lot and maybe explain it and yeah. And then I'd be curious, Monique, if it ever comes up when you're talking to young people today, if they even know what it is.
Well, I think, for me, the idea that you are, so U equals U stands for, is it untransmissible or untransmittable? I know both words are used, but undetectable equals untransmissible. So you do not transmit the virus when you have a durably suppressed viral load. As a person who lived with the virus for a long time, not knowing whether I could give it to my friends and family, let alone my sexual partners, the idea that you would be on treatment, virally suppressed and non-infectious, was revelatory and changed my life. It made me feel so much better about myself. It made me feel safer around other people, and it helped me relax and it helped them relax. I think it takes a bit of time for people to believe that that's true. We can tell them that this is the science, but until people live through the experience of it, it takes a while to understand that that's true. I've lived with the disease for more than 2 decades, and I remember in the very early days when my sister handed me her newborn baby to wash. And at that time, we didn't know whether or not I was, whether I could, transmit the virus. Obviously we didn't think we could through casual contact, but I'll never forget that gesture that she made towards me and what that made me feel. It made me feel that I was normal, that I was safe, that I was regular. And that was very powerful. So I think today we need to really amplify this message and help people understand that the more people we get on treatment, the more people who become virally suppressed, the less chance the virus spreads. And that's really important both for their own safety and the safety for the people around them, but it really helps us accelerate access to treatment. It's a justification for access to treatment as well as prevention. So if we're doing both together, if we're increasing our efforts on prevention and including including PrEP, and we're getting a lot more people on treatment, eventually we will have a population where the risk is really reduced. I mean, we don't have a similar tool yet for COVID, but we're able to mitigate it with behavioral changes, mask wearing, social distancing, and hand washing, all those things. So I do think that U equals U is a powerful campaign to help destigmatize the disease. I think we need to to continue the work to amplify it and help people understand that as a person living with HIV, I'm not going to hurt you. And also, I think even just when people are tested and aware of their HIV status, the reaction of most people living with the disease is that they would be very highly protective of other people. So even just the fact that you are aware of your HIV status is a projective thing, but certainly when you're on treatment, you are very safe, and that makes you feel better. So
I agree with Regan. I work with the younger population, so my I'd say 13 to about 16-ish young people, they actually don't know, because we of course mention it, U equals U. We have trainings that we do for young people. We also, sidebar, we also have a peer education route that we take with our young people. We do have young people between the ages of 13 to 24 that actually work for us as community messengers and peer ambassadors. So when we're giving the training, we absolutely, teach them about U equals U so they can go and disseminate that information to their peers. But most young people between the ages of, I say 13 to 16 don't even know what U equals U is. And when we do mention it to them, there is that stigma that Regan talks about, because there is already the stigma around HIV. So I'd say it's been a little bit difficult with young people. They just need a lot more education about it, a lot more knowledge for them to understand.
Jim, may I add a comment? So I think the other thing that's been interesting in the arc of my discussions with people who are close to me since I've had HIV, I finally came to the realization also that they're safer with me actually than they are with a person of unknown status, because I know what I have and I take my pills every day, and I know that I'm virally suppressed because I get viral load tests regularly. So I know I'm not going to give something to someone else, and I'm very, very careful not to get anything else on top of what I already have. So, there's this misperception that people with HIV are, dangerous or, sickly or infectious. And of course, that's often the opposite. We're often very well informed about our health and regularly are seeking health services. So we know a lot about our health, and, this is a deadly disease. You have to take your pills to survive. It's not a maybe I'll take them. So, and that's why retention and care is really important, because we need to make sure that we are giving people the opportunity to remain virally suppressed in a durable fashion. And I think viral load testing, expanding that globally could be very helpful. And again, educating people on the importance of adherence as it correlates to viral suppression and to being, unable to pass the virus along.
I think as a global and global community, we haven't done a great job on raising awareness about whether we call it U equals U or we just say, hey, if you're on treatment and virally suppressed, you can't transmit. And also about PrEP, that we just either haven't had access to the right, the large, big enough megaphone to and messengers to provide that. But in the current context where we're hopefully in the next few months or however long going to have a COVID vaccine or vaccines, we're going to have to combat these challenges. This whole topic that we're talking about tonight is really about the challenges of embedded racism and other structural inequities. And I think there's a real risk that when there is a vaccine, because of a whole host of reasons, those who have been most at risk for COVID are also going to maybe not be first in line, and then of course not get the information about getting the vaccine and face other kinds of barriers. And I think that's people living here in Washington and then wherever we work, that's probably one of the biggest challenges we're going to face for sure.
Well, and I think that's when we talk about reinventing healthcare or our approach to healthcare or universal health coverage, it is certainly an essential part of the equation to think about putting people on the front lines and people at highest risk at the front of the line, not the back of the line. And we have been supportive of a campaign called the People's Vaccine at UNAIDS, which is advocating for a free vaccine for all people. It will be challenging as nations wrestle to secure vaccines for their own people. But again, in a world that perhaps some countries would like to think nationally, the reality is we are globally connected in ways that are, we cannot disconnect, and no country is an island. And even if we have travel bans, we cannot stop the spread of the virus necessarily. So we do need to think about this from the perspective of a global community. And the Secretary General of the UN speaks a lot about this. If we want the COVID pandemic to end fastest, we have to really focus on those at highest risk and make sure that we get vaccines and care and services for other diseases to the people who are most at risk. And that's to me what the future of health is about. How do we crack that code? Because that will keep costs down and make the world a healthier place faster. It's not perhaps politically possible in some places immediately, but that's why we have to advocate for changing people's minds about it.
Okay, I'm going to just see, does anyone have any other questions? Because if there aren't questions, I'm going to see if Regan and Monique want to just say, there are some summary thoughts, and then maybe go back to our host to see if they want to, actually Lanice is going to close it, but does anyone have any other questions? I know we threw out a lot of terms and they might not have all made sense. So now's a good time. If you have them, you could just type the question. You don't have to speak it. Please just let us know. And so why don't we, I'm going to ask each of you just if you have any summary thoughts or things you want to share about your work or what you're hopeful for, or how we're going to get out of this mess. So please do. I'll start with you, Monique.
Yeah, so summary thoughts, continue to, at the, of course, the local and global level, just continue to advocate for your health, advocate for people of color who could be your neighbor, sister, brother, cousin, whatever. Just advocate at the local level. I'm not too sure about the global level. I'll let Regan talk about that. But like I said before, like speak to your council members, your ANC, go to the hearings, like anything that has to do with your health and making sure that, people who are at a disadvantage can also be on a level playing field.
Mm-hmm. Regan?
Thank you. I would just say that, the terrible tragedy that's ongoing, that is COVID, provides us a really awesome opportunity to have different conversations about global health and also infectious disease. And I hope that we can use this moment to, as an HIV community, come forward, and we are first responders on the ground. Many of the people working in the HIV space, from community healthcare providers to advocates in capitals, have done all of this before, and we can be very useful. We're here to help. We want to both help with COVID. We also would love to continue our work on HIV and AIDS. So we need to protect the progress that we're making on the diseases that we've been mandated to end. But at the same time, we are part of the larger group of people who want to make the world a healthier place. And we won't do that unless we focus on women and girls' needs and on human rights and on putting people at the center. And this has always been where UNAIDS has been its strong suit. We can't, diseases happen to people. They're not medical phenomena only. They are in human bodies and human lives, and we have to meet people where they are, and we have to embrace people in their great diversity and make sure that we give them equal access to the right to survive and not suffer. So UNAIDS is very happy to be part of the conversation tonight and with all of you, and we would love to partner with any of you on advocacy here in Washington. Thank you so much for tonight.
Wonderful. I know we're going to turn back to Lanice, but there is a question that Monique, if you want to answer it. Yeah, great.
Yes, I do see it. It is possible to join COVID and HIV testing at Whitman-Walker Health. We have been doing that. So it's something that's already in the works.
Great. Yeah, and I know actually a lot of HIV clinics around the country are doing COVID testing as well. So
Yeah.
and around, I think, and around the world. Okay, Lenise, thank you to both Monique and Regan and everybody, and thanks for letting me be part of this. I'll turn it back to you, our host.
Yes, thank you again, Regan, Monique, and Jen. This discussion was very informative. Thank you again for lending your time and your expertise. Again, everyone, thank you for joining us this evening, and we're grateful to our partner, HipPolitics, for helping us bring this event forward. And just a little bit of information about the Women in Global Health DC chapter. We were established in 2018, and we'll continue to partner with organizations around the world to present relevant events on women's health and gender equity. Our calendar includes at least 2 events per quarter on programs, policies, as well as social networking opportunities. We look forward to meeting everyone in person, of course, when it's safe to do so in the near future. But in the meantime, if you do have any questions or do want to get added to our listserv, please do email us at wghndc@womeningh.org. Have a good night and stay safe.
Thank you so much.
Thank you so much.